Tubular proteinuria. What are different types of proteinuria first of all? You have functional proteinuria which can occur by strenuous exercise, fever, orthostatic proteinuria, thyrotoxicosis, anemia, exercise, etc. Whereas tubular proteinuria, any pathology involving the tubule like interstitial nephritis. Similarly, any pyelonephrosis or gouty nephropathy or analgesic nephropathy or nephrolithiasis or Fanconi syndrome or heavy metal intoxication, any of them can lead to development of the tubular proteinuria is what you have to basically remember. What do you see in this duodenal biopsy? You find the atrophy of the villi, which is the classical feature in case of celiac disease. So celiac disease, the oat, rye, barley, they cannot be safely given. It is associated with gliadin, dermatitis herpetiformis, and there is an anti-endomysial antibody, and there is a risk of development of cancer is what you have to basically remember. Different types of respiratory failure, you have to be doubly sure. Type 1 is there is a hypoxia with a normocapnia. Type 2 is hypoxia with hypercapnia. Then what is type 3? Type 3 is perioperative respiratory failure. Typically, whenever there is any atelectasis of lung, either from a shallow breathing due to the pain or anesthetics or narcotic drugs, that lead to type 3 perioperative. Type 4 is called hypoperfusion respiratory failure. Whenever you are in a cardiogenic, hypovolemic or a septic shock, then hypoperfusion to the respiratory muscles lead to development of a respiratory failure, which is called type 4 respiratory failure is what you have to be doubly sure about. Which type of porphyria? Photosensitivity is not a feature. Acute intermittent porphyria, correct answer is A. So there is abdominal pain and neuropsychiatric symptoms. Whereas cutaneous tarda, hereditary coproporphyria, variegate porphyria, there is photosensitivity. Similarly, congenital erythropoietic porphyria, protoporphyria also there is photosensitivity. So you must know the differences between hepatic porphyrias, non-hepatic porphyrias, what enzyme is deficient, what is the clinical presentation, where do you have psychiatric symptoms, where you don't have, everything you have to be doubly sure. So what is fourth heart sound? Fourth heart sound is also called atrial gallop. When the ventricle is getting filled, first 1/3 of the filling of the ventricle is because of the pressure difference, the movement valves open between atrium and ventricle. Second 1/3 due to gravitational pull. Third ventricle atrium actually contracts and pushes the blood into the ventricle. Suppose the ventricle is very stiff, non-compliant because the left ventricular hypertrophy, then atrium has to use a lot of pressure to push the blood into the ventricle, and that leads to fourth heart sound is what you need to remember. So if there is a atrial fibrillation, atria cannot produce fourth heart sound. It is typically correct answer is it is present during the late part of the diastole, not the early part of the diastole is what you have to basically remember. Last 1/3 of the ventricular diastole during which atrium actually contracts, that time you will listen the fourth heart sound is what I want to underscore to all of you. Now, in the CCG you are finding a sawtooth pattern which is called atrial flutter. Catheter ablation is considered to be a good therapy. It is a narrow complex, not wide complex, narrow complex tachycardia. It is a macro re-entry circuit in the right atrium. Generally, right atrial flutters are common. Sometimes there can be left atrial. And the rate at which atrial flutter occurs is at around 300-400. But all those atrial impulses will not go into ventricles because the AV node will block it. That's the reason often it is associated with 2:1, 3:1 kind of a AV block is what you have to remember. Now, whenever you are doing treadmill, what type of ST segment changes you call it as positive changes is a very, very important question. So it is the downsloping depression, not upsloping, is considered to be the sign of a positive feature. You can see this is an example of a upsloping type of a ST segment depression. ST segment is depressed, but it is upsloping, which is a benign feature. Whereas here if you see, it is straight descending down. So horizontal ST depression or a down sloping depression. So this is considered to be a positive treadmill is what you have to ultimately remember. So this is an example of a normal ECG, and post stress, how is the ECG ST segment depression? It is a horizontal depression. Is it benign or pathological? It is pathological. You have to worry if there is a horizontal depression or a downsloping depression. If it is a upsloping ST segment depression, then it is considered to be a benign change is what you need to remember. So how another easy way of remembering is, if it is a downsloping or if it is horizontally depressed down, then he is going into the graveyard. If it is upsloping means he is rising out. So it is benign. That's what you can remember. Acute ischemic stroke, you will be using cerebrovascular accident, you will be using aspirin or a recombinant tissue plasminogen activator is the one which is used in order to manage a acute cerebrovascular stroke is what you need to remember. So what do you have here? Fragmented RBCs, which is a sign of hemolytic process. In hemolysis, there is an increase of unconjugated bilirubin, and since there is no obstruction, that increased bilirubin can go into gut and convert into urobilinogen, and urobilinogen is excreted into the urine. But be careful, unconjugated bilirubin cannot cross the kidney, hence there is no bilirubin in the urine in hemolytic anemia, but there is an increased amount of urinary urobilinogen. Let me come back to you. A lot of students have confusion on this very important area. I don't want you to have confusion. See, this is liver, doctor. This is your gut. So whenever the RBCs are broken, you have the bilirubin which enters into the gut, converted into urobilinogen. Urobilinogen is absorbed back into blood and it will go to the kidney and it is excreted into the urine. So urinary urobilinogen is increased in case of hemolysis. But the bilirubin, some of the increased bilirubin is released into the blood. It is an unconjugated bilirubin. This unconjugated bilirubin, when it reaches kidney, it cannot enter into the, it is not filtered. That's the reason urinary bilirubin is negative, but urobilinogen is positive in case of hemolytic anemia. What happens in case of obstructive jaundice? The bilirubin released is a conjugated bilirubin, because in obstruction jaundice still the conjugation mechanism is intact and that enters into urine. So urinary bilirubin is increased in case of obstructive jaundice. But because of this obstruction, bilirubin cannot enter into the gut. So urobilinogen is not formed. That's the reason the urinary urobilinogen is absent, but increased urinary bilirubin is seen. That is obstructive jaundice. If you find the urobilinogen in the urine, what does it rule out? It rules out the possibility of, if you find urobilinogen in the urine, that means there is no obstruction. Then if you find bilirubin in the urine, that means it is a conjugated hyperbilirubinemia, which is the typical feature of obstruction. So that is how you basically interpret, is what I would like to underscore to all of you. Hope it is very clear for all of you without any confusion. These are all simple concepts, but people carry tremendous confusion.